Welcome back to the Daily Drum on WHUR and Sirius XM, channel 141. This is the Insight segment. I'm Harold Fisher. Tonight, a Wellness Wednesday conversation. We are taking a closer look at Tourette Syndrome beyond the headlines. Now, last week at the BAFTA Film Awards, a well-known Tourette's advocate involuntarily shouted a racial slur during the ceremony. Now, that outburst was broadcast internationally, and it has sparked intense debate about disability, race, and media responsibility. Well, tonight, we're breaking down what Tourette syndrome really is and why this incident has ignited nationwide conversation, as well as how advocacy is urging greater understanding, not mockery, of a condition that affects thousands and yet remains widely misunderstood. My guest is Dr. Shannon Dean, pediatric neurologist at the Kennedy Krieger Institute. Dr. Dean, thank you so much for sharing some time with us and discussing this. I appreciate it.
Thank you for having me.
Sure thing. I guess the first thing that I do want to ask you about, I'm sure you heard about the BAFTA incident, and as an expert in this field, what was your initial reaction? Was it shock? Was it surprise? How would you characterize it?
Well, I'm going to limit my comments on that specific incident, but I would like to talk a little bit about the kind of tic that is relevant, which is called coprolalia or copra phenomenon, because that includes foul gestures. So this is something that happens to about 20% of individuals that have Tourette syndrome or chronic tic disorder. So the majority of patients won't actually have a tic that severe, but for the ones who do, it can be extremely distressing. Tics can be extremely difficult to control. One of the metaphors I like to use is it's kind of like having something that is itchy and that you need to scratch it. Often if the itch isn't so bad, you're able to suppress it at least briefly, although sometimes when you do that, that feeling or need to do the sound or do the movement gets stronger. And sometimes if it takes you by surprise, if it's just really intense, if you're tired or distracted, it can come out even when you don't intend it to. Most patients who do have coprolalia find it extremely distressing and embarrassing, and it tends to be one of the more severe kinds of tics that causes the most morbidity. But again, it doesn't occur in the majority of our patients.
Why do they call them tics?
So tics is a word that we use to talk about how it's a sudden, abrupt, repetitive sound or movement. It's spelled differently than the insect. It's TIC instead of TICK. And we generally categorize the tics in a couple of ways. We talk about vocal tics, so that's sounds. That includes words and swear words, but it also includes things like sniffs and snorts and coughs and grunts, and motor tics, which are usually repetitive, brief, abrupt movements. So that's eye blinks, that's facial grimacing, that's neck jerks, that's shoulder movement. Neck jerks tend to be one of the more severe movements because if it's a violent neck movement and it's very fast, you can actually hurt yourself or cause injury that way.
When we look at who is most impacted, what has been your professional experience? Children, is this usually when the diagnosis happens?
Yes. So usually tics start sort of in those early grade school to preschool years, somewhere between 4 and 6 or 7. At that time, they're often quite mild. And actually, if someone really watches kids like a hawk, like watches an entire class of kids throughout an entire school year, about 20% of kids will briefly have a tick or two, but for most of those kids, the ticks will go away after a few weeks or a few months, and they're easily missed. Often people don't even notice them. For more like 1 to 2% of kids, they will continue to have ticks on and off and on and off for a longer period of time. And so to meet criteria for Tourette syndrome or other chronic tic disorders, you have to have had your tics for a minimum of a year. What we expect, if you're one of those 1 to 2% of kids that continue to have tics on and off, is that they're likely to peak between about 9 and 12 or 13. So that tends to be when the tics are the most problematic. If the tics are going to be embarrassing or painful, that tends to be when that happens. And then for 2/3 to 3/4 of kids, somewhere in the high school years, the tics are going to improve spontaneously, regardless of what we do. Some to the point where they're almost gone. For many kids, the tics are only going to be bothersome sort of in those middle school years, if they're going to be bothersome at all. Unfortunately, it's the folks that have the more severe tics, the tics that are more what we call complex. So that includes things like words or phrases or more complex gestures, where they're more intense, where they're more frequent. Those are the patients that unfortunately are less likely to have that improvement spontaneously in adolescence. So there are lots and lots of people walking around that technically meet criteria for Tourette syndrome, but whose tics are so mild that they may never need intervention. We just ride them out and wait for them to get better on their own. There's many, many people where they do need an intervention, but they respond to a mild first line thing, and it's a temporary need for something because they're going to grow out of the tics mostly anyway. And then there's a small minority where the tics are more severe and are more intense and don't get better, and where they do need more extreme measures to try to control them, and where those measures may not actually work.
Who are most impacted? Is this something that we see more in boys or girls, and why?
Well, we don't know exactly why it is, but we do know that for every 3 to 4 boys with a tic disorder, there's only 1 girl. So it does seem to be more common in boys. There are certain disorders that tend to go along with tic disorders. So tic disorders are more common in folks with ADHD or with obsessive compulsive disorder, OCD, or with anxiety. And the more of those comorbidities you have, the more likely you are to have significant or more serious tics as well. I wouldn't say that adults are more affected because there's fewer people that continue to have bothersome tics as an adult. On the other hand, of the people that continue to have significant tics as an adult, they tend to be the people that have had severe tics all along. So our adult colleagues are often dealing with folks whose tics are considerably more bothersome than what I see in my clinic, even though there are fewer of those patients.
So you mentioned ADHD, but this is not necessarily, or is it, in any way, shape, or form linked to the autism spectrum? Because certainly we do know that some research shows that those who are on the autism spectrum, boys often outnumber the girls.
That is a great question. So while autism isn't as strongly linked as some of the other disorders that I mentioned, there is an increased risk of tic disorders in people with autism, and there's an increased prevalence of autism in people with tic disorders. So it's somewhere about 20 to 30% of folks with autism have enough tics that they would be diagnosed with some chronic tic disorder. Not as common as some other things that you see in autism, but certainly more than you see in the general population. There may also be some shared risk factor genes that increase your risk of both autism and ticks. And the way we think about these risk factor genes is it's a little different than some of the genetic disorders we have, where it's a specific mutation in one gene that always, if it's going to be expressed, causes one set of symptoms. In disorders like autism and ADHD and anxiety and tic disorders, we think instead that often there's a lot of commonly expressed variants that we may all have, and you have to have a certain number of those slightly pro-tic or slightly pro-autism or slightly pro-anxiety variants to have any symptoms. And we see that these risk factor genes are often not only for one disorder, they also increase your risk of some of the other disorders, which is why we think they tend to travel together.
This is fascinating to me because, and just kind of just doing a little research
Mhm.
on this ahead of talking to you. One of the things when you look at kind of the history of this, and I'm sure you are well aware um, that this was first described by French neurologist Georges Gillet de la Tourette.
Yep.
Is that correct?
Yep.
1885. Yeah. So, and forgive my French. I did not do well with French in college, but I can only imagine, and certainly are historical reports dating all the way back to the 15th century, where what we now know as Tourette syndrome was seen as demonic possession, for
Yep.
example, and certainly we can only imagine what happened to those people in the 15th century. But we don't even have to go back that far. Even I'm sure back in the 17th century, 18th century, until Tourette kind of diagnosed and made observations about this, that this was problematic for those who were afflicted by it, and even if they were not the subject of persecution, they were certainly the subject of isolation.
Absolutely. And I think, being attributed to demons, or earlier than that, being attributed to some sort of affliction by the gods. The
Mm.
other problem we run into with this disorder is it's easy to think that something is causing it when it's not, because by its nature, we expect tic disorders to wax and wane. So you often have periods when your tics are quieter, and periods, often stressful periods, like being sick, being worried about something, even being excited about something, when your tics might be more prominent. And because of that waxing and waning nature, it's easy to fool yourself about what is causing the tics. So it's easy to misattribute the tics to being caused by certain circumstances, or a particular infection, or a particular time of year. This actually happened in the medical community not that long ago. We thought for years that stimulants made tics worse. The data actually suggests that's not the case, and that one of the things that we were being fooled by was the fact that we tend to start stimulants when kids aren't doing well at the beginning of the school year. And those tend to be stressful periods that tend to bring tics out anyway. And so, that I can only imagine that if you're in the 15th or 16th century, it's also pretty easy to fool yourself that some particular thing in your environment, a certain person, who you might think is casting a magic spell on you, could also be the cause of all of your suffering. So there's a lot of problems that can come up with that. And yes, absolutely, these tics can be very isolating, particularly because sometimes they look like people are doing them on purpose when they're really not.
And I do want to talk about that too, because full circle now, in the 21st century, still there is a stigma attached to it, and I want to get your opinion about how those who have Tourette syndrome, what your experience is, and how they deal with being in the public, and just, what we as people who are not familiar with it, how we should address that. Also, I want to talk about treatments and all of those things. But if you'll just hang on for just a moment, we are going to take a break. Don't forget, you can hear this and every edition of the Daily Drum Insight segment via podcast on WHUR.com. The original Quiet Storm with Raheem Devon is coming up next on WHUR-FM. This conversation continues on Sirius XM channel 141 in just a few seconds. Welcome back to the Daily Drum on Sirius XM channel 141. I'm Harold Fisher. We continue our Wellness Wednesday conversation about Tourette Syndrome, the neurological disorder recently in the spotlight after a racial slur was shouted and heard at the BAFTA Film Awards last month. My guest is Dr. Shannon Dean, pediatric neurologist at the Kennedy Krieger Institute. Dr. Dean, the thing that I've often wondered over the years when I've been exposed as a news person, we obviously these issues come up periodically when we cover health issues. But after the incident at BAFTA, I began to wonder when these corporalia, is that the okay? So the shouting, I often wonder why the tics, the verbal tics, are often coarse, foul, racist, sexual, and I'm just wondering, first of all, why that happens, and why we don't hear more of someone having an utterance like butterflies, sunshine, lemon juice. You know what I mean? Often when we hear about Tourette syndrome, and I've been looking on social media and watching those who, in the wake of this incident at the film awards, they try to, explain, but even in the midst of it, they will have a tic that will be overtly sexual and inappropriate, which to me is, in a word, just fascinating and so difficult for us who are not exposed to those who have Tourette syndrome. It's really difficult to understand.
So I think there's a couple of factors here, but I do think a big one is attention and the fact that these tics are shocking and sensationalistic. That's when we notice the tics. I have seen kids who had tics like apple, or, words like, okay, things that can kind of be disguised into the conversation that you might not pick up on. And that's to say nothing of the kids that have what we consider to be vocal tics that aren't words. So coughs and sniffs and snorts. So if you see a kid that's coughing a lot, you might be irritated that they came to school when you think that they have a cold, but you may not necessarily think about the fact that they have Tourette syndrome. We know that social media can be a driver of stigma in patients with tics and Tourette's. It's something of a double-edged sword, because it can also be a way for them to advocate for themselves. But it's also been observed that when advocates who themselves have Tourette's have videos that show some of the more severe tics, whether that be the vocal tics or more significant motor tics, those are the videos that get more views. People are curious. People have a prurient interest when it is rude or shocking words. And so you end up with sort of a vicious cycle where we think more of the swearing tics of coprolalia because that's what draws eyes. That's what we remember and pay attention to because it was significant. And that's what more people end up watching.
Well, I'm old enough to remember life before social media. and so, I ask why the more shocking verbal tics, why the sexual verbal tics, why the cursing. I guess that's the thing that I'm curious about, because long before social media, even in being in this particular career, and
Mhm.
seeing films. And let me take you all the way back to PBS. Now you just know how old I am, but but all jokes aside, yes, I've seen those obtuse, foul, overtly sexual ticks. And again, so I guess my question is, why do we see those as opposed to an adult, and I'm speaking specifically about adults
Yep. Um,
who may have those verbal ticks instead of shouting, something like apple pie or sunshine, as I said, or lemonade.
I think there's probably a couple of factors there. When you're talking about adults, again, they tend to be the folks that have had tics the most severely all along. And so when you're just looking at the adult population, you're going to have an enriched population of people that have more severe tics. And of the vocal tics, coprolalia is often considered to be the most severe tics. I do think another part of it is, again, uh, media follows things that are interesting, and an adult that coughs a lot or that sometimes says in a sentence where doesn't particularly make sense, doesn't make for particularly interesting TV, doesn't make for particularly interesting shows. Talking a little bit about how we think tics happen in the brain, and why they occur. So one of the current theories is, so there's this part of your brain that's called the basal ganglia, and its job is to help you plan how you're going to do whatever it is you're trying to accomplish. So if you're trying to pick up an apple from a table, it's the part of the brain that kind of sorts through the portfolio of all the movements you know how to make and helps you string together an arm movement that gets your hand to the apple and then back to your mouth. We think in the brains of people who have Tourette syndrome, this area is a little bit hyperexcitable, so it sends a little bit too much through, and it doesn't keep back all of the movements or all of the sounds that you could make that have nothing to do with what you're trying to accomplish right now. And we think that the result of that is you get a little fragment of a motor plan that kind of gets stuck for a while. So, for example, you might start with actually having a cold, and start coughing because you do have phlegm in your throat, but then the cough is retained well after the cold has resolved. So that little fragment gets stuck in there like a bead that you vacuumed over, and it's kind of rattling around in there before it finally gets sucked up. Why did the swear words get
Yeah.
stuck? Well, I don't think that we have a good answer for that scientifically, but you could speculate that these are words that we use that are associated with high emotion. Sometimes those emotions are anger. Sometimes those emotions, in the context of slurs, are shock and disgust. And you might speculate that those high intensity emotion words may be a little bit more prone to get stuck, that there may be something self-reinforcing there, because stress tends to bring out tics. And if that particular tic is a stressor, you could get into a little bit of a vicious cycle where the tic comes out more because it is distressing you, which causes more distress, which causes the tic to come out more. There's no proof that that's the case, but based on what we know about tics, one could speculate that that could also be a contributing factor.
Yeah, and I think that's an interesting answer, because again, and I'll give you an example. I was watching a young lady who was, and you may have seen her. I would assume that she was probably in her 20s, a
Mm-hmm.
young adult, and she was there with her fiance, and she was trying to explain it, and in the middle of her uh, very reasonable discussion, she all of a sudden gave a double bird flip,
Yep.
and and dropped off two F bombs, and um and in my mind I'm thinking, why? As opposed to, even if it could have been a tick as the one you were describing, where it could have been a or some kind of other non-understandable, utterance. But in the same vein, she also, during that discussion, in the middle of trying to explain, came a hello.
Yep.
And so, yeah, and so it seems to be all jumbled, and again, curious about it, why these things come out, because I would imagine those of us who do not have Tourette syndrome, if you're watching a football game, a couple of us have dropped, a couple of bombs, when our team is not doing what it's supposed to do, and that is not certainly a neurological disorder, although we could probably question what our parents taught us growing up about being polite. Um, let's talk a little bit about how this is treated, and I would imagine this goes along the spectrum of minimal tics all the way up to severity. How do you treat this with? Is it different for children? Is it different for adults?
So the very first line of treatment is education. So talking about the tics, talking about what we expect of the natural history, coaching the kid to say something like, if they're asked, why are you blinking, or why are you making that funny face, or why are you making that funny sound, say something like, my brain just makes me make these little sounds and movements sometimes. I'm not really doing it on purpose, but it's not a big deal. And for some kids, that'll be enough. Just that little bit of self-advocacy and education will get them through. Their tics are never going to be severe enough to warrant more. So that's usually what we try first. If the tics are distressing in some way, so they're embarrassing the kid, they're getting the child in trouble at school, they're interfering with schoolwork in some way, you're blinking so much that you keep reading, you're losing your place when you're trying to read your assignments, or they're painful. So you're moving your head so hard that you're giving yourself neck aches or headaches or anything like that. That's when we start to do intervention. The first line of intervention is something called Comprehensive Behavioral Intervention for Tics, or CBIT. So this is a behavioral therapy intervention, and it relies on two things. One, we notice that while tics are often worse when you're excited, when you're run down, when you're stressed out, we also notice that they tend to be quiet when you are doing something purposeful with your body, when you are playing the violin, when you are actively kicking the soccer ball, things like that. At least for many patients, sometimes they don't stop, but they often tend to be better than that during those periods. And we think that when you're actively doing something purposeful, that signal may swamp out the tic signal. So it relies on that. Plus the fact that if we think about tics as an itch that you have to scratch, something that tends to make you feel like you have to do it, that can be suppressed for brief periods, but with discomfort in doing so, we know that when you've got something like that, that awful itchy feeling does get worse when you're trying to suppress it, and may come out more significantly for a while. But we also know that if you're able to ride that sensation out, that awful sensation does go away. So for example, if you've ever been driving down the highway, right, and you're really itchy, but it's a windy, fast highway and you can't spare a hand, that awful feeling gets worse and worse and worse, and it builds, but eventually it peaks and you can kind of ride down the other side. So what we teach people to do is what we call a competing response, something that is physically incompatible with the tic. So if your tic is to jerk your head to the right, maybe you turn your head to the left and lean your head on your hand, because you can't do both motions at the same time. And you learn to hold that competing response for increasing periods of time. So we have the kids hold their competing response for 30 seconds, and then they can let their tic out. And then the next time they do 1 minute, and then they do 3 minutes, and then they do 5 minutes, and then they do 10 minutes until they eventually extinguish that particular tick. And once you've extinguished that particular tick, then you can move on to the next tick that actually bothers you until you're left with stuff that's barely noticeable and at most mildly annoying. And those you can safely ignore. So that's the first line of treatment. But it doesn't work for everybody, and it's a big time investment. So this is usually 8 sessions over 10 weeks. There's homework in between. So the kid has to be pretty invested in getting this tick gone for it to work well. And it's really hard. It's a lot to ask of little kids to suppress that feeling for long periods of time. If that doesn't work, or it's not practical, or it's not accessible to the family, then we think about milder medications. The most commonly used medication is guanfacine. So this is a medication that was developed to be a blood pressure medicine. It's not a very good blood pressure medicine at all. It doesn't really do much to your heart rate or blood pressure usually, but it seems to be good for a lot of other things. So it reduces hyperactivity and ADHD. It can take the edge off of anxiety. It's usually not a primary anxiety medication, but sometimes it's an add-on when the standard stuff isn't enough by itself. And it seems to be pretty good at suppressing tics. So that's usually the first medication that people try. It can be sedating, though. It can make kids pretty sleepy. And so that can limit how useful it is. And again, it doesn't work for everybody. If you've exhausted things like guanfacine, or there's a couple of other medications at that level of intensity, there's things like clonidine, which is closely related, or Topamax, which has a different mechanism, then we're starting to talk about sort of bigger guns. So these are usually medicines, is what we sometimes call antipsychotic or neuroleptic medication. So that's things like risperidone or Abilify, aripiprazole, even things like Haldol, haloperidol, things like that. These medications are significantly stronger than CBIT. And significantly stronger than the first line medications, but they can have some big side effects. They can affect your metabolism, how your body processes sugars and fats, and can give you high blood sugar or high cholesterol levels. They can affect your liver or kidneys and cause liver or kidney injury. And they themselves can cause their own abnormal, involuntary, uncontrollable movements called, for example, tardive dyskinesia. So we're very...
Oh, wow. And we see a lot of that. We see a lot of pharmacological commercials about tardive. Help me with I got my medical degree out of a Cracker Jack box, so forgive my pronunciation. But yes, I have seen that. Yes.
So those are big deals. That means that, that can be limiting. You can have a medication that seemed like maybe it was helping someone, but you have to stop it because they have one of these side effects. And even with these medications, there's a tiny minority of patients that are not going to respond to those either. There's been some experimental trials for patients who don't respond to any of these options, things like deep brain stimulation. That's where they actually do brain surgery, and they put a little electrode in your brain that stimulates at a certain interval that tends to suppress the tic. That is considered an experimental therapy. It is usually not covered by insurance, and the places that have those trials running usually require you to have failed everything else, CBIT and one of the non-neuroleptics and 2 different classes of neuroleptics before they will even consider you. In my clinical experience with the kids, I would say 20 to 40% of kids are never going to need any intervention. You do education, they move on with their lives. Another 40 to almost 50% of kids are going to need something like guanfacine or CBIT. And it's a tiny minority of kids that I am starting on neuroleptics, and an even smaller minority that I am starting on multiple neuroleptics and starting to get desperate and thinking about things like brain surgery, because most of our kids will respond to one of those much milder interventions if they need something.
as it relates to adults, and you said you talk about anti-anxiety medicines.
Mhm.
What about we know that in some cases uh, the use of cannabis or cannabis-like uh, drugs can help with anxiety. Would it help um, with Tourette?
I would say that the answer is maybe. I haven't seen a convincing clinical trial that suggests that's the case. I will say, in my own clinical experience, not with cannabis, but with some of the
And
standard
not with
anti-anxiety
kids. Yeah,
medicines.
right.
Yep. So with things like Prozac or Zoloft, sometimes you'll get a kid come in and they have tics that are really bothersome, and they have pretty bad anxiety that's out of control. You know, they're having trouble sleeping on their own. They're constantly complaining of stomach aches and headaches when they have to go to school because they're getting so in their head about, going to school. The anxiety is really running their lives. And you're going, which of these two bothersome things do I want to treat first? Sometimes, if you treat the anxiety first, so you use your Zoloft or your Prozac or your other related agents, the ticks calm down. And then you don't end up having to target the ticks independently. It's not that the ticks are a direct symptom of anxiety, but because these are closely related things, there is a tendency for things to function poorly together. So when your anxiety is bad, your ticks might be worse. And if I can get your anxiety under control, your ticks might calm down on their own without me having to target them directly.
What impact might physical activity have on tick-related Tourette syndrome? For example, particularly when you're dealing with young children or adolescents, they want to play football, they want to play softball, they want to do volleyball, they want to lift weights, they want to run track. Uh, do those kinds of extreme athletic pursuits help, hurt, or have no impact on Tourette?
That's a great question. So, at least while you're playing the sport, things are often quieter, and we think that exercise in general has a positive impact on mood. It does help you calm down. It helps kids with ADHD re-regulate themselves. It helps with things like anxiety and depression. So I wouldn't say that for someone who has bothersome tics that just signing up for football is going to be a magical cure, but being engaged in those physical activities may help both while you're actively playing the sport temporarily and then more in a long-term sense by helping to regulate your mood and helping you feel better, which is going to tend to decrease your tics in general.
Finally, when you talk about stigma and social
Mhm.
settings, even when you're talking about adolescents or young adults, what do you tell them about how to deal with um, outbursts and kind of maneuvering in
Mhm.
in the community? And I'll give you and the reason I ask this, I was speaking to a colleague who is a college professor, and she was saying that there are other people in a class that she teaches. She said there's someone who is legally blind.
Mhm.
He has a uh, a cane where one of the long canes that allow him to figure out where he's moving. But at one point, he walked past her and struck her with it accidentally.
Yep.
And and his response, because he was obviously well aware of his disability, that he apologized immediately because it was something that was unexpected.
Yep.
uh, but when you're talking about Tourette and someone has an outburst, God forbid you see a lady and you utter something sexually inappropriate. How do you tell them to address that in the greater society?
I think that's a great question because that explanation of, it's something my brain makes me do. I'm not doing it on purpose. That's easy for kids when they have mild or at most annoying ticks. It's a little bit harder when you've got a tick that is just louder and more disruptive. So a screaming tick in the middle of everybody taking a test, or a foul or more embarrassing tick in that sense. So there's a couple of things we can do. The explanation can help. We do encourage people to apologize if they accidentally hurt people. But one of the things we also do is we start to talk about accommodations with the school. And in those settings, the accommodations are for the comfort of everyone, hopefully the comfort of the patient that is having the symptoms, and also the comfort of everyone around them. So, for example, if a kid's got a really bothersome loud tick, but they're one of those kids that has enough control to at least get out of the room, one accommodation might be that the teacher makes up an errand, or the kid just has a automatic quote unquote bathroom pass, where if the tick, really bothersome tick, is struggling to get out, they can go out of the classroom to some private location and they can kind of let the tick out there. And then once the tick is out, once they've scratched that itch, then they can come back to the classroom and continue what they were doing. That might also mean that they need more time on their assignments or more time on their tests, because if you're walking out in the middle of your test to release this tick, you might need an extra few minutes. For adults and in the workplace, that might take the form of permission, for example, to work from home on certain days when your ticks are really bad, and to have your camera and your microphone off in Zoom meetings when your ticks are really bad, without your boss thinking that means that you're, secretly playing video games in the background, things like that.
Dr. Shannon Dean, this has been a fascinating and very edifying conversation. I really appreciate the time that you've given us to kind of explain and to help us understand Tourette syndrome. I really, really appreciate it.
Thank you so much for having me. It's been an absolute pleasure.
That is the Daily Drum for this Wednesday, March 4th. I'm Harold Fisher. Good night.